All right. If everyone feels ready, I can start. See, everyone's okay. Great. Welcome, everyone, to our panel, Centering Disability in Healthcare. I'm Dr. Jen Rinaldi. I use the pronouns she, her, and hers. For an audio description, I'm a white woman with glasses and a short brown pixie cut. I'm wearing kind of a paisley print, orange and green dress, flouncy sleeves today. My background has a white wall with plants, and I think there's a picture of a, you can't see the picture today, but you can also see my couch. I'm an associate professor at Ontario Tech University and an event co-organizer and coordinator. I'll begin with the land acknowledgement. Ontario Tech University, the university that hosts this series, is proud to acknowledge the lands and people of the Mississaugas of Scugog Island First Nation. And we're thankful to be welcome on these lands in friendship. The lands we are situated on are covered by the Williams Treaties and are the traditional territory of the Mississaugas. That is a branch of the Greater Anishinaabe Nation, which includes Algonquin, Ojibwe, Odawa, and Potawatomi peoples. We start here because we must be mindful that the disability researchers we are speaking with today, they will be doing work in community and on lands that have a history of dispossession and colonial violence. That is historical and ongoing. So this panel is part 3 of our 4-part virtual series that's been called Advocates Assembly, Disability Research from the Ground Up. The series is hosted by the Institute for Disability and Rehabilitation Research, which is an institute that was established in partnership with Ontario Tech University and the Canadian Memorial Chiropractic College. The IDRR is committed to conducting applied research that is relevant to policymakers involved in disability and rehabilitation. In this vein, this series has meant to connect disability and rehabilitation researchers to community-based research principles and goals. Across this series, disability justice activists and disability-centered health and social service providers have spoken to the lived experiences, the in-community conditions, and the most pressing needs of disability populations. And they've done so in an effort to frame the future of disability and rehabilitation research. I should note our next event, I think it's called Advocating for Disability Justice, will take place December, I want to say 7th, Wednesday evening from 6 p.m. to 7:30 p.m. Eastern Standard Time or Toronto-based time. I will be sure to include the event link in the chat once I shut up. But first, I'll note, and the event link is important because if you want to register for that event, that's how you get the December link. But first I'll note that this particular project we're joining to learn from today was funded by a Social Science and Humanities Research Council Connection grant. We're also really grateful to SLIAO for providing ASL interpretation services today, and the Canadian Hearing Services for providing live captioning, which is available on your screen. Professional artist Ann Abbott created original work for our promotional materials. You'll see her beautiful painted landscape in our poster work and our registration page. So if you want to support disabled artists, her work is available online for sale. This presentation is being recorded and will be available eventually on the Institute website if you're interested in using it as some kind of pedagogical or public tool. I wanted to note the chat window is open for engagement. We ask that audience members turn off their cameras and microphones for the duration of the talk. And during the question and answer period, you can raise your hand. The button on the screen should enable you to do so. You're welcome when you do that to turn on your camera and microphone to ask a question directly. And you can also pose questions in the chat window, which I'll do my best to collect and to read to speakers should we have a Q&A portion towards the end of our talk. So that's all my business. I can start yielding the floor to our esteemed panelists. I thought I'd start by letting you introduce yourselves. So my first big question for you is, would you like to introduce yourself, your affiliation, and your own contributions to disability and rehabilitation research? And I'd be grateful if you wanted to provide a description of yourself as well for accessibility purposes. Whoever wants to start, let me know and we'll pin you on the screen. Taryn first. I see you like.
Good afternoon, everyone. My name is Dr. Taryn Eckmeyer. I am a white woman who uses the pronouns of she, her. Today I am wearing a gray shirt and a blue background. I have glasses and really fashionable earrings on. I'm very happy to be here today. My role is of executive lead of research, innovation, and knowledge mobilization at Grandview Kids. If you're unfamiliar, Grandview Kids is Durham Region's largest and only children's treatment center, providing outpatient services and specialized medical services to children ages birth until about 21 years of age. We provide services such as occupational therapy, physiotherapy, social work, therapeutic recreation, among many specialized clinics, including our complex care program run with the Hospital for Sick Children. Interesting to note, last year we served just over 16,000 children in our region, and we have an additional 11,500 waiting for services provided in center, at school, and licensed childcare, and on occasion within the home. My roots in pediatric rehabilitation sciences began as a knowledge translation specialist at Holland Bloorview Kids Rehabilitation Hospital. Some of my key projects I got the opportunity to work on included creating a chronic pain toolbox for children with physical disabilities, and including a systematic review that has been published in the Journal of Pediatrics. And then when I come to engagement with families, one of my core research projects was looking at the assessment of body mass index and having conversations about overweight and obesity with children and youth with physical disabilities. And then later at Holland Bloorview, my work continued as a research coordinator and scientific writer. And there that work focused on supporting families of children who are born preterm with neurodevelopmental disorders, such as cerebral palsy, and that transition process between the NICU, neonatal follow-up, and then community services. I have since transferred over through some work with the region of Durham, now landing at Grandview Kids in the place where I live at Durham Region. For the last year, I was on a secondment contract acting as the Director of Strategic Communications, Partnerships and Engagement with Grandview Kids, which oversees the Family Leader Program. So we have a very established program, which I'll talk about a little bit later, with the Family Advisory Council, the Youth Advisory Council, and a very well-known family engagement team. I'm now leading this new portfolio of research innovation, and I'm excited to share with you today some of our work around engaging the voice of children, youth, and caregivers in our work. Thank you.
Thanks so much for that start, Taryn. Francis or Dilshad, do you want to go next? Who wants to go next?
So I will jump in.
Great.
My name is Francis Garwe. I'm a Black man. You might not see my height today, but I am 5'11", an inch shy of 6. Dressed today in a light blue shirt. I'm putting on my tie and my jacket. Jane, in the earlier invitation, I wanted to make sure that I was going to be presentable than most. If you find me on a sporting field with my kids, I'm probably often wearing a t-shirt and the loudest screaming parent supporting the kids on the side of a football field. My pronoun session are he and him. I've been with Career for the last 6 years, and I'm the CEO for the organization. Our mandate as an organization is to provide healthcare across Durham Region's 401 corridors, towns or cities, which include the Oshawa, City of Oshawa, Municipality of Whitby, Ajax, Pickering. We border right at the Rouge Valley extension with Scarborough. Majority of some of our specialized work, which covers the work that we do from newborn kids all the way to the most senior person in the community. We cover work for primary care, which means your regular doctor's visit. We also have recently acquired a pediatric care clinic, which serves children who are under the care of Children's Aid Society, which used to be a clinic that was run in partnership with the pediatricians in the community. However, with the view of wanting to provide integrated care, we put our hand up as an organization to be present in that space so that we can give all the necessary required services for all children, youth, and families in Durham who would require some of the services we offer under the banner of Career, which is laterally everything that keeps you well. And fortunate today, we are sitting here with some of our well-respected partners, Grandview. We call transfer or refer families into our services. Some of you during pandemic, when you recall, all the operations in Durham region and across Canada were closed. We remained open, but what was also unique during that time is the partnerships that we have with university, Grandview, Children Aid Society, as well as many other small community agencies, which are grassroots. We were able to be a center of support with all services regarding case management, including some of the things we have never done, helping pay bills for families who are struggling. Majority of the families that we continuously had to keep close and near to our heart during the onset of the pandemic were families with disabilities whose access to services were not as easily found as the rest of the community members. And we are actually continuing as an organization to be very intentional and deliberate in how the services we build and create should be tailored for community members who are most prevalently disadvantaged in accessing care across or services across the spectrum of services that are available in the community. One piece that I would say we actually did quite well in this last year of the pandemic, we had 11,000 families that we saw, all of whom constituted close to 33,000 visits in the full year, and accessing services that range from medical supports, but also all the way to food security supports. And majority of what this work that we are talking about today is going to be us sharing what role do we play in supporting families who are in Durham, who are impacted by some of the challenges that we see in the society today. So we'll be sharing more about some of these services for Keria and how families can access some of this work, but also looking at the research. What is it that we can contribute from either knowledge of the work we do, but also some of other supports that are specifically geared towards individuals we are talking about here with disabilities across our community. So I will pause here to give others opportunities to jump in. And thank you very much. I look forward to hearing some of your questions on how we can be of service to you and to the community that I also call home in Durham.
Wonderful, thank you so much. And I'm going to turn it over to Dilshad next. Let's find her. Sorry, to bear with me.
Okay.
I'm trying to figure out spotlights. There we go.
Okay. Can everyone hear me?
Yes.
Okay. My name is Dilshad Kasam Lalani, and I am a nurse practitioner. Today, I'm wearing a white shirt and a beige jacket. I'm in a office alone with the door shut, and my background is blurred. I go by she, her, hers pronoun. I'm very pleased to be here, and thank you for the invitation, Jen. So I am a clinician practicing as a nurse practitioner at Holland Bloorview Kids Rehab Hospital in the spina bifida and spinal cord injury clinic, serving youth ages 14 to 19 years, and in partnership with Vibrant Healthcare Alliance, ages 19 to 25. Vibrant Healthcare Alliance is a barrier-free community health center. Apart from providing medical care, my role has a large focus on ensuring seamless transition from pediatric to adult care system. I'm privileged to work within this unique interprofessional model to promote self-management and determination. The program is evidence-based, and in keeping with the rehab model, our team comprises specialty consultants from sick kids, therapists such as physio, OT, speech language, a psychologist, orthotist, as well as nursing support. Additionally, we are afforded with 3 very important roles in promoting independence, which include life skills coach, youth facilitator who shares her lived experience, and post-secondary transition specialist. In terms of my contributions to research, I'm in a unique position whereby my practice informs research and vice versa. Another privilege afforded to me, seeing firsthand patterns or trends of responses to chronic illness and disability at the clinical level, which I see as a ground level, since the stories are those of our clients and patients that have gaps in care. To bridge this gap, I contribute to quality improvement projects at Holland Bloorview and also formal research by teaming up with our research team. Our clinical programs are generally linked with an assigned research team. I'm proud to say that Holland Bloorview has a research institute and currently expanding within its walls, and it is recognized in Canada and around the world for leadership in the field of childhood, youth, and young adult disability. In addition to conducting research, Holland Bloorview plays a big role in knowledge translation or evidence to care. An example of patterns of responses to chronic illness and disability that I came across very early on when I started my role were mental health concerns and needs. In teaming up with our psychologist and research team, we conducted a research study to understand the mental health and wellness needs of young adults with spina bifida. This study was conducted through a stakeholder engagement workshop, which then led to co-creating a research question for further study. I also participated in research through a consultative role, such as in our sexuality study, which has been published, forming partnerships for recruitment and engagement as a study participant. We are very privileged to have this model whereby we have partnership with Vibrant Healthcare Alliance. And our partnership also consists of conducting research between Holland Bloorview and Vibrant Healthcare Alliance.
Thank you so much, everyone, for such fulsome introductions. I'm always floored by the pedigree of our panelists. I'm so grateful to have you all here with us today. I think now we get to move on to some real substantive questions, and you're welcome to continue to take turns, but you can also have conversation, and we are looking to you as experts when it comes to how to inform research. My first big question for you is, how should community-based research look? Like, what should it look like? And I'm wondering how it looks from start to finish. Do you have any examples from your own experience of challenges and strategies for success? Who would like to go first?
I can go.
Wonderful, thank you.
It's still shot. That's a great question. And at Holland Bloorview, our experience and my experience has been that we should include stakeholders to co-design and co-create research questions, as well as knowledge translation tools. Some of the challenges that we have encountered include recruitment, and I think that may be across the board, perhaps. Coordination in participatory research, because we do need to be very respectful of stakeholders' time, as well as some of the barriers that they often face. The other challenge is attendance, attrition, time commitment, financial barriers for families to take time away from work or from family, as well as transportation. Childcare is another one. Some of the successes that we've had is in recruitment is partnerships. So partnerships with Vibrant Healthcare Alliance, partnerships within our programs, posting our research on websites and inviting patients, stakeholders, clients across the board who have disability or complex needs. We have provided childcare at some instances, And in terms of recruitment, I think that one of the most effective ways I've come across in my personal experience is role modeling the importance of the issue that we're studying or want to study or understand, the relevance, and being excited about it, and in a very caring approach. And I personally have had a lot of success in recruitment when I use this approach.
I love this idea that recruitment starts with care. Thank you so much for leading the discussion, Tashad. And I will turn next to Francis or Karen. Sorry.
Sure, and thank you very much for starting us on the note that you just shared, and without repeating, some of the areas you covered, just to add, would be an ability for a successful research is to think from the beginning and the basics of the environment in which the work is happening, the physical presence to allow the participants, their families, their colleagues, and it could be also some of other supports they bring to make sure that it's inviting. It creates a sense of calmness as they interact with the space. Some of the examples that I will add, which we just recently launched in Durham, we developed one of the only kind service for gender health. The services were only given in Toronto at Sherborne, as some of you refer some of your other early young youth into the services. So in that space, what we had taken a real deliberate approach to do as an organization was to dive deeper into community engagement. The invitation of not only the direct subjects of gathering, where we are gathering information, but also their caregivers into this space, and creating a space for caregivers sometimes to be part and parcel of the voices that are contributing to this space. As you would appreciate, in this recent work that we have done for gender care health, it's work that looks anywhere from the environment that the conversations are being held, the language and redesign of that language, working with the participants, to also understanding the semantics in the space and how culturally sensitive the questions and the conversations are, so that they actually are presented in non-intimidating way. But like any work that includes some research, is you want to make sure you also hear the voices behind the voice, in which you get to gather some of the nuts and bolts of the opportunities and the challenges that may exist. The other pieces that we have also been able to deliberately inject was the understanding of the multiplicity of barriers that come into place. The previous speaker just spoke right now of things like compensation. For us, we also looked at things like, an environment like that, what would that need from the foods that are there, but also transportation that is being accessed. Does that meet the needs of those families and their partners as they come in and leave? An example, what we know in Durham, even when we are sending families to see kids, that trip, as much as it's an hour and a half for all of us, the families who are facing challenges with disabilities, you notice that trip is about maybe close to 4 hours in preparation, or sometimes it can be 5. Because think about the things that you and I, who are in this space, would take for granted. It's not the same as those families. So when we are inviting them to come or to participate in the work or even clinical visit, those elements are actually built into the understanding. When you visit a career space, from the washroom that we use, to the language that you see on the wall, we always have to make sure that it's built with that deeper thinking in mind to allow the degree of comfort. And the last speaker spoke about daycare, and I would not say much, with the exception of adding that within the space where you're inviting families with young ones, understand the experiences of those young ones who are coming in that space, that the mere presence of this maybe new space is by its own way intimidating. So the ability to be able to design the space in a way that invites, allows much of the contribution to come from the participants. When families come to us, one of the things that we put under consideration, it's the other supports that are within the organization that can help a family to navigate even our own internal process to work with them. We call them warm handoffs, so that when that moment comes to which we are asking questions, we are collecting responses, we are able to make sure that it's done with ease. And also it allows the opportunity for the participants to ask questions in ways that it allows them to either use their own semantics. And in most of the cases, we even go to the length of engaging third parties like Access Alliance to do language interpretation, to also do some of the cultural supports that are required before engaging. And I know most of us, we are familiar with Indigenous cultural competence, but there's also the Afrocentric cultural awareness when we deal with other folks that are coming from other regions of the world, whose understanding of the Canadian culture different and sometimes impedes them from being able to get the best maximum support they need. So all these elements are part of what we want to always call the outer skin of the onion that would remove the tears at the beginning of the process to allow ongoing engagement.
Thank you so much, Francis. I'm going to turn next to Taryn if you're interested in tying up the question.
Thanks so much, Jen. And yes, to the other panelists, everything that you've said, I'm in full agreement with. At its root, community-based research is participatory. So it is driven by the needs and the lived experiences of the community. And that needs to be defined first and foremost. Who is your community? Is it the clients? Is it the family members? Is it just caregivers? Is it your staff? And you have to build trust with that community. And that is very difficult to do off of just a flyer, come participate in a research study. So making partnerships and connections across the region to like-minded agencies, as Francis was saying, warm handoffs that might happen within the sector or system is a great way to say, how do you engage with your families and how might we collaborate? And notice that I'm using that language as how might we. It is not my role as a researcher to come in and say, this is what I want to study with you. It is how might we collectively answer the research question. But let me take a step back. Before you even identify that research question, you should have a family advisor or a patient advisor or an advocate be a part of that research team. So one example I can use is that we hosted a symposium for research priority setting. And this is around that discussion about obesity and overweight with children and youth with disabilities. And we had an equal distribution of parents and caregivers, medical team, and clinicians as part of our discussion. We were very conscious about the potential of power imbalances. So just as Francis said, we had a neutral place to meet. So it was welcoming for all, and everyone was familiar with that space, because it's very important that research is very intimidating. Just the consult process to get to a research question should be comfortable. So we had the opportunity to ensure every voice was heard through arts-based data collection, I should say. So everyone could express themselves in different ways rather than just, here's a survey of our research questions, what should we focus on first? There was a group priority rating session, and then there was an accountability back to that community to say, here's what we heard and here's where we can make feasible change that will be both impactful for the research team as well as for the community. For the ideas that cannot be carried forward, there is still an accountability. What will we do with those ideas in the future? And how can we address those questions? Sometimes it's a no, or sometimes it's a not yet. So you can build a portfolio from the outset just by engaging your community. I also wanted to make a note around respecting the cultural practices and traditions. I had the opportunity to work with Nagdwigma Banujiag Child and Family Services over the past 2 years regarding the overrepresentation of Black and Indigenous youth in child welfare systems. And one interesting component is I was designing a co-design model, thinking that how would we start the conversation and what would that look like? And their executive director told me, we will start when we are ready and we will finish when we are done. And if I was in the academic hat on, I would say, how am I going to fit that into a 60-minute focus group in my budget? So that is where you have to have lots of flexibility of working with your community. And if you're unsure of that work, you have to take that on upon yourself to learn about the community that you want to engage with. And it's not just reading articles or blog posts or social media, but it's immersing yourself within the community to have a better understanding of their lived experience. I have a huge list of potential things, but I won't jeopardize the conversation with a lecture of best practices. One thing I would like to also mention, at Grandview Kids, we use something called the IAP2 spectrum for public consultation. And I'll put the link to the spectrum in the chat just after I'm done speaking. And this is a spectrum of where along the engagement spectrum do you anticipate community members to be engaged. So it goes from a starting point of you're just being informed. So we're disseminating the information out to you. Here's what we're doing. But we are gradually involving the community members all the way into empower. And that's an ideal stage where the community members will tell you what to do and you honor their voice by following exactly what they do. It has to do with selecting your recruitment processes from your data collection instruments, having a voice in the knowledge mobilization plan. And so I'll share that when you're designing your next community-based research process, see where it is appropriate and who will be accountable and responsible to engage the community along this ideal towards empowerment. And lastly is honoring the voice. So let's imagine that you've involved a family member in the research process from the beginning all the way to the end. How are you going to honor their voice? And so we have started at Grandview Kids a new role that we call family advocate. And in that way, they can participate in committees, in research projects, or in quality improvement initiatives. And at the end of it, we ask them, how might we honor your voice? Or how might we honor your time? And some options we give are, we could provide you with a gift card. We could make a donation to the Grandview Kids donation, or you can just accept it as volunteer hours, and we're happy to do that as well. There are some guidelines of what you can do for an honorarium, and I'll include that in the chat as well. That's from the organization known as Child Bright. So I can see my panelists nodding, and Francis wants to add something in, so I'll hand it over to you, Francis.
Thank you very much. Well articulated in terms of honoring the voices. But what I enjoyed a lot, in terms of cultural dynamics, when you interacted with the Indigenous child welfare, when the term was used, we'll start when we are ready and we'll finish when we are done. I think that, tells us truly some of the things that were part of the challenges with the older methods of collecting information and research, in which when things are organized academically and a certain process sometimes misses that cultural nuance, there's a lot that could be missed in the story. And it's almost like when you're on a trip, you are driving, you are only worried about getting to a destination and not knowing that part of the journey is probably that lay-by stop to see what's along the way, right? So a couple of things that I wanted to add in here that are part of the challenges, which I felt I missed in the beginning. We are dealing with the communities in community-based research that is overly researched and sometimes overly sampled in terms of gathering information from surveys, in which the research and survey fatigue is a thing in the communities that we are in, specifically the priority populations we are identifying as disabled and or those that face multiple barriers to getting supports. Every year when there are research opportunities that come out, I think for most of you who are in the caregiving service organizations like ours at Career, you receive lots of letters to be asked to participate in this work. And you end up always going to those same communities to invite them, in which now, for most of them, will be like, wow, we've done this before. And, when the information was shared, the loopback cycles were not properly linked for us to understand what became the final outcome of the work. And I know Jen will get to that question later on. What does that look like when we know we have done the work and we've gathered enough? How do we look back? How do we make sure that happens? So some of the strategies that were challenges there is understanding how to ensure, especially at the beginning when you are creating a process of engagement, how do you make sure that you collaborate with other partners should similar work happen with your counter organization colleague? You can think of partnering so that you don't overtax the same group of participants that have done this, which might impact or color or flavor the outcome and miss the bigger picture. How do you do that in a collaborative environment? An example of what we have in Durham, specifically in the child and youth space, we have the network of children and youth within Durham that we are learning to work as a hub. Even in the spaces that we exist now, when you see some of the newer locations that we're establishing as a hub, most of the organizations that are even right now at the Children Ed Society building are organizations who are serving the same kind of clientele and who probably have existing partnership agreements, in which if questions are coming in, or opportunities for change and improvement in serving a community, you collaborate to to manage some of that risk of fatigue in survey, in research, so that you can get a real rich data that you end up sharing as a network on the best practice that might meet some of that those communities or family members that you are trying to save. Anyway, I wanted to add on that, and thanks very much, Terren, for opening that window.
Dilshad, I saw your hand was up. Maybe you have a follow-up?
Yes, I just wanted to echo both Terren's and Francis's comments, especially with regards to participation. And at Holland Bloorview, we're quite privileged in that, we have a family leader program, and it actually participates in all aspects of Holland Bloorview, which include from creating a vision, priorities, research, clinical guidelines. And the Family Leader Program really tries to empower our stakeholders, our clients and patients to participate and to bring their voice to the table so that the policies, the research is informed. And I 100% agree, and we've had challenges around overtaxing, overstudying the same population. It is a huge issue, actually. And I'm really looking forward to discussing some of the strategies that maybe Francis or Taryn have come across and used that have worked. Thank you.
If I go adding my spotlight. Sorry about the tech issues, everyone. There we go. I want to thank you all for such a rich discussion on this first question and your sharing of your incredible insights. I think my big takeaways are that it takes so much work to develop trust with this overstretched, over-researched population. And it's so important to build partnerships, and yet our partners are themselves overstrapped and overtaxed. So how do we build trust? Sounds like you're doing all this incredible work to start from the very beginning of formulating your question, so it's actually in service to community. You're thinking about timelines because these ongoing issues are going to persist long past our grant funding wraps up. So our timelines aren't always going to match what needs are in community space. And then this important work around thinking about environmental conditions and creating inclusive space, and contending with how complex and intersectional accessibility can be, strikes me as a component to building trust. And I really love this question that Taryn's offered: how do you honor voice? Because what else is the purpose to the research? I really am grateful. What an excellent discussion and follow-ups. Are we okay to move on to the next question? All right, this is more substantive. Since you do work on the ground already, you know what the key issues are plaguing community today. I'm wondering, what should academic disability and rehabilitation research prioritize right now in order to meaningfully meet community needs and expectations? Who wants to go first?
Mine is quite short. So I can just add, no matter what your research topic is or where your interests lie, I highly recommend establishing an approach to community advisory councils or community advisory groups, conducting your own research and identifying the best practices or promising practices that others are doing well to engage families. And don't wait until you have to check a box off in your research grant application to say, yes, I've consulted with these groups. Start developing those relationships now.
Taryn, that sounded like a total summary of all of it. It is so poignant and straightforward. Adding on to that is, we spoke earlier of building relationships. We understand there are individual relationships, but as a research institution is establishing institutional relationships with those community organizations who have decades of years of relationship with the population that you are about to research on. An example, you are sitting here with the three of us who holds massive years and experience of service to the community. Some of the family members, we meet them at birth when the child is coming out of child and maternal delivery unit, all the way when you look at Grandview. They are not leaving the kids. Sometimes even when there is an aging out approach, the families continue to be connected. I know, talking to Dr. Caroline Hunt at Grandview, you hear stories, and also Dr. Chris Montgomery, the stories of when they met the families when they were little. Today, they could be 21 or 22. They are still within the network of supports that those agencies or organizations where that institutional relationship has resided and has been born out of. There must be key elements of the researcher or the researcher who is doing the work. That's number one. Number two, always continue to understand the value proposition of a triple helix model that allows an organization such as a Grandview, a Carrier, a Vibrant, a Hollandview, who is already in this space doing direct savings giving, but also there are other institutional relationships that you bring from, say, a research organization like a university or a medical facility like a Sick Kids who does that. And there could be sometimes, which I've seen often in my practice, in my work in US, with a pharmaceutical company who might be also maybe in another space of providing some support, or it could be any other third party. To ensure those relationships must be discussed prior to getting to the front of the family or a caregiver group who is gonna contribute the information. The reason I'm bringing this information in, oftentimes, institutions who are going through research, if they are not clear on the objectives of the work, their dysfunction happens to come out in the front of focus group of the patients and families they are supporting, which completely devalues the intention of what that research is supposed to yield to meet the needs of the community.
I wholeheartedly agree with Francis that Taryn provided an excellent summary. And also, I agree with Francis about teasing out at the outset of the partnership, you know, what that partnership looks like, what collaboration looks like, and who plays what role. And also, in my experience, discussing the issue of authorship. That often does come up if it hasn't been teased out at the beginning or at the outset. And if not, then it can unravel very quickly. And it's sad because it often comes up at the end when it's time to publish. And so when we're collaborating with academic institutions, other institutions, larger institutions, smaller institutions, it doesn't really matter. I really think that that relationship needs to be defined and how it works and behaves. And I wholeheartedly agree with Taryn that those relationships with our stakeholders, with our community, have to begin early on in order to build that trust. And the one thing is that relationship building through partnership, I can't say enough about. Thank you.
Thanks so much, everyone. Glad to have a pithy answer for this second question, which helps with time. It sounds like we're thinking through some of our institutional ties, how those relationships are shaped. And I really love this idea of an advisory committee as an accountability measure. In fact, my secret mission for this speaker series is to start building the foundations for an advisory committee that can direct our own institute's research agenda. Maybe we feel ready for the last question of the panel. My big last question was, How can disability and rehabilitation research communicate findings to key stakeholders? I think this was touched on earlier. So Francis is ready to take the pin out of that question. And I guess my follow-up is, in what ways can that work advance public policy or produce meaningful transformation? Who'd like to go first? I love how shy you all are about going first when you have such genius insights. Francis first.
So, and thank you for that. And what a challenging part in the sense that, as much as sometimes we might feel, oh, the work is done, so the easy thing is just communicate it back. So let's not forget that process should not trepidate purpose, right? So, because if you think about this, the intent, the purpose of why the work is happening is crucial and important. Always understand that process is a brain, is a baby of the purpose. So when we start the research, you present a problem statement or an opportunity, and also what's in it for the participants, for the community, for the family, for the institutions. And Jane, you just spoke earlier about, one of the takeaway is establishing the advisory committee and making sure that that is a huge vehicle of also where you invest some of the relationship for the ongoing work. But also think about this, because we are talking about disability. When you look back the communication back to the community of the findings, also think about multiplicity of perspectives and the listening in between of how those messages are going, and thinking about the audience who is going to be getting that information. And when we all listen, everyone who is getting those results back or that communication back, there are some that are going to have a very direct action that is going to come out of that. There are some that are inferred as supports to the action that will come out. And there are some that will probably maybe play one role of being an advocate or being a mouthpiece. But how does that get to land effectively? I would always say the biggest responsibility is to the contributors to make sure that you are as sensitive as possible to not only the privacy of the information, things that could have been shared in that space, that could mean quite significant of a direction in which it doesn't end up actually become a trust destroyer in that space. So that at least tomorrow, when there's further communications, those groups must be able to find a place where the sanity of the secrets of the message and the voice continue to reside. But also thinking about multiple forms of how that information goes out. We have a typical example here. We are speaking. We have an ASL interpreter in understanding who needs to hear the information, how do they hear it, and do they have the right medium of making sure that when the information is going back, is being communicated, it's understood in its core entirety way. And remember that purpose, why we were doing what we are doing, are those objectives being communicated in the way that it addresses what was the question first, so that at least the appreciation of that work going forward can see its roots into what that work is. The one piece that I would also add is that sometimes it's easy to focus on the end goal and missing that the starting goal is the fundamental foundation of the success of hearing, understanding, and responding to what is needed.
Wonderful. Thank you for that strong start, Francis. Who goes next?
I can answer if you'd like. So I always imagine that knowledge mobilization is the art side of our science. And this is across all sciences. I'm talking about bench level science as well as qualitative inquiry. Again, I love, Francis, what you said is, what was your purpose? And when I read the question first, it was saying, what do we do to advance public policy? And so I'm going to base my answer off of this. And the term of knowledge mobilization is really about a reciprocal action of information sharing, receiving, and then followed up by another action. So what is that call to action tailored toward the specific audience groups? We all have to publish papers holding on to your academic status. That is the currency within the sector. So do that, but what is it? What's the next part of it? To advance public policy specifically, because my PhD research was an evaluation of an education legislation process. And it was, how do we now translate these findings into inform the legislation? And so the first thing I would suggest that as a practical next step is for everyone to understand how public policy is developed, reviewed, evaluated, and updated. Because if you don't know that process in full, and it's pretty easy to understand, you end up doing things that are ineffective and a lot of wasted time. So I'm not saying that letter writing campaigns are not always effective, but in order to really make change, you need to have relationships with either your local MPP or a federal minister and their policy advisors within those offices. And you're not handing them a research article and say, you need to read this. You're providing them with like, here's the quick win. Here's what, if your government adopts this change, here's the success that your government will see. That what's in it for me is really something big that our government will be looking for. And then it's backed by the research evidence followed after that, which is really hard to do when you've spent maybe 3 or 4 years conducting a study that was quite comprehensive and has a huge methodology, but all they want to know is what's the key takeaway and how is this going to make a change in our society. So I would really encourage everyone to consider those stakeholders and their unique way of receiving the information. And going back to my thesis research, we had the opportunity then to connect with the policy advisor team within the Ministry of Education and present upfront to them, starting off with, here's our formal recommendation for a simple change to improve the healthy school environments. And here's our research next to provide it. So listen to my first 10 seconds of my speech, and then you can tune me out and answer emails if you need to. So keep that in mind, and I'll hand it over to Dilshad for any additional comments, and I'm happy to talk more or answer questions about knowledge mobilization. Thank you.
Thank you so much, Taryn. And, following your suggestions, and I wholeheartedly agree. And I have an example actually of what you're speaking of. And that example includes the model that I practice in. It was a model that was introduced about 10 years ago, I would say, based on the evidence, based on the gaps in the clinical environment. And so the model was created based on the literature, and thereafter, or at the same time, was studied as to what the outcomes are going to look like. Are they what we thought? Are there new learnings? That sort of thing. And we did find that what we wanted to do was achieved. And it was the right dose, it was effective, it was good practice. And took it to the ministry for funding. And while initially we had monies for it to be a pilot, at the end of the research, we were able to present the research, the outcome, the process outcomes, and we were able to get a permanent funding for the program that I'm currently in. Thank you.
Thanks, everybody. It sounds like we've been talking about relationship across this conversation. I find that so important given how disability cuts across relationships and involves some caregiving, some mediation work. If we're imagining our roles as researchers, trying to encompass that and trying to ourselves serve as mediators or mouthpieces, it sounds like talking about relationship at the core of what we're doing seems so essential. And I do really like this call to really think through what our purpose is, because we're not engaging in disability research we shouldn't just for the novelty of it, just for the curiosity of learning as a kind of intellectual exercise. Like, we're talking about real people's lives and how to advance the conditions necessary for their own well-being. So when we think about our research projects, imagining their end point, like what we want to do with this research, seems like a really important place for us to start. I'm so grateful to you all for such a rich discussion about these themes in your own work. I'm happy to yield to you all if you have any final thoughts. Otherwise, we can turn over to our Q&A. We feel ready? Okay. But just as a reminder.
So Jen, as we go,
Francis.
oh, sorry. So Jen, as we go into this question period, hopefully, I can articulate if there's any one key takeaway from this, which we had consistently from the beginning, is if you are not clear with the purpose or the questions that you want to uncover, you have not invested in the meaningful relationships, not for what you want, but what is intended from both angles. And if you have not also been ready to appreciate the value of the support system that is coming from those you are interviewing, and we have heard about the advisory council or the family supports or any other structures that are around the subject, probably it's the opportunity as an audit process to say, we are not ready, let's go back. And once those are really in place, then probably you can consider going back. And one last final piece, it's not just about the funding that might follow that. I think Taryn has covered it very well, that yes, you might think of galvanizing letters of support from the community, loudest voices to go out and say something, but also think about that 10-second elevator executive summary that will catch the attention of the intended recipient of that document or research, to ensure the actual implementation and the strategies will come and follow that funding. I think those were really good summaries that, when I listen in, and I always say, yeah, I need to make sure those are bigger buckets that I set on there before we start to engage on anything else. And thank you for that.
And might I just add to that, Francis, is a great way to involve the community is to have them do the pitch. Have them, something that we used to do at the Region of Durham is called the story behind the curve. So if you're working with a lot of quantitative data, what does that mean? What does it look like on the ground? And this power of storytelling can really shape what happens next. So thank you so much for bringing that point forward.
What a fantastic close. I think we might be ready then for the Q&A. I will just remind the audience that if you have a question to ask, you can raise your hand. If you want to speak directly, you can, you're free to turn on your microphone. You can even turn on your camera if you want to be spotlit. You can also pose a question in the chat, and I'm happy to read it aloud. I know that it's always a bit of an awkward transition into Q&A, so I'll give you all a moment to think through your questions. Maybe I'll just note to this panel, I mean, I come from a field that, and from organizing efforts that often struggles with trusting medical providers and health researchers. And I think that's because of like histories of medicalizing disability have come with a lot of harm. So I really am so moved by how sensitively you approach your own work and how you center disabled voices and community voices in the work that you do. Because I think that's the way forward. That's the way we build trust. So anyone have any questions to pose for our panelists? Give you another moment. If you don't, I think we might have at least a comment in the chat. I'll read it aloud. Thank you for the amazing talk. Oh yes, here's a question. I was wondering how to reach those disabled families that are isolated and are not part of any community. So let's think through some of the access issues that you have brought up in an early question, because there's some real barriers to accessing families that experience poverty and disablement. What are our thoughts?
I could talk about a little bit about some of the work that we have taken into consideration when designing research studies. Is we always want to ensure that we're allowing equitable access to participate. The first thing is that if we are entering into a research project, that it has a formal research ethics review process attached to it, and that we provide families with an information letter that includes all of the transparency, its risks and benefits associated with their participation, a very clear rationale and what they're expected to do, and that there must be some sort of response back that you're demonstrating accountability. Because as Jen just talked about, not everyone has a trusting relationship with the healthcare system. So how in the organization, not just within research, but across all, are you showing accountability and a commitment to honoring and sharing the voices? I bring up that information letter not just because it's a standard practice, but because I really want to emphasize the opportunity within that letter that states you are able to withdraw the study at any time and it will not impact your services, who you can talk to if you have any questions, and what type of supports are made available are written in there before they make an informed choice. And that's always an inclusion of, don't remember who said it at the beginning, but about, support for transportation, especially if you have a child with a disability or you have a disability on yourself and require accessible transit. How do we ensure that if you need to be in person, that you have access? If you prefer to have it in a different language or have a family member who speaks an English and wants to interpret for you, or we can give you an interpreter to participate. If participating in a focus group isn't for you, is there another ways that we can honor your voice and opinion? So is that a survey? Is it a one-on-one interview? There should be accommodations made. If people have a voice and want to contribute, then we should be able to listen. And the isolation part is quite difficult because that could also mean like they don't have access to internet or stable internet. So are we providing them with a written copy of the information that's also available in their mother tongue or a language that they're most used to at a literacy level that makes sense, and things aren't written at so complicated in academic terms that no one knows what you're trying to achieve. So, and then there's an opportunity too, like at Grandview Kids, we will say, there is a community that you can be a part of through our family engagement team. And here are the offerings that you have free of charge. It's open. You can access it in many different ways that are meaningful for you. And even if you don't participate in your study, here's an opportunity to connect with caregivers and parents that might be experiencing similar challenges or opportunities in their lives. Oh, I wonder if Francis and Dishad have anything else to add on that topic.
Dashan, I'll just jump in and say the beauty that you have today in the speakers that are sitting here, we are all coming in from service-giving organizations. The question specifically about those that are isolated, maybe this is where I may come in with a pitch to say, you are speaking to the right cohort. Carrier Community Health Center, despite some of the specializations we do in the primary care, one of our key mandates is building and supporting community from wherever we find them, and work with them through them guiding us what they need to support them and connect them with these other resources that they will identify as needing. There will be, of course, opportunities for us to suggest other supports. But when you talk about loneliness, isolated, barriers to resources to get to services, know that there is zero fee for all the services, from medical supports all the way to case management supports. For you as the family member who is challenged with disabilities of any kind, to reach us out. We even send teams to your home or to that location where you are to support and make sure that if we are not the right support for you, we will find somebody that can fill that part for you. That's our job as the CHC. I think you hear the same about what our colleagues at Vibrant. That's exactly the mandate that we are funded for. CHCs are one of the only model in Canada with physicians and service providers that are paid salaries, where you don't have to worry about limitation that my family would have to mortgage their house to get support from these teams. So, and the question does not have to be medical, it's anything. So I may be digressing there, but I just want to make sure that barrier 101 of accessing and asking questions and getting a rich, warm hand is right here.
Thank you for that, Francis. And I was just going to say, community health centers, and Vibrant is one of them, and that's where I work. And I also have a history of working in primary care in community health centers. You know, they have a mandate to work with those who are marginalized, hard to reach, and therefore partnerships with community health centers really does become key to be able to reach some of these isolated clients that we may not come across, or they may not have internet to have a look at the websites, inviting them to participate in research, or may not come to our clinic, etc. And so I do think, Francis, yes, community health centers, I think, are a key to partner with to reach those hard to serve people.
Wonderful. Thank you so much for answering that first question. It does strike me that CHCs are such a valuable resource when it comes to reaching especially marginalized communities and impoverished ones. And the more I say community, this next question reminds me that the term I think is used so much, sometimes it loses all meaning. So I appreciate Shane Walker's next question. Like all communities, the disabled community is not homogenous. So the question is, how do you ensure the different needs of the heterogeneous communities within the broader community are met? Who wants to take that question first?
I might just provide a simple question, or sorry, a simple response. First and foremost, not making assumptions of what the requirements or accommodations or no accommodations and requirements are needed. And so going back to maybe one of my earlier points of asking the question, how might we? And so engaging and saying, how might we best engage with you to have you participate in research? And asking those questions and having conversations. And I think partnership plays a huge strength in that, and sharing lessons learned, but hearing directly from the community members, not making assumptions, asking how might we.
But how might we? Does anyone else want to answer this question?
I could make a comment in that with respect to the heterogeneous communities and the broader community. You know, that's an excellent question. And I truly feel that this can be met only through partnerships between primary care and specialty care, and doing the research together in order for us to be able to capture the voices in the broader community, because it is heterogeneous and there are many different needs. But they can certainly, perhaps we may be able to try, using Terrence's words, through partnerships with primary care.
And I think Francis gave an excellent answer in the chat. Listen, listen, and listen. I'm okay with letting it rest there. I think it's such a useful question to ask. I myself work with intellectually disabled populations who've been systematically removed from community space historically, and now experience such impoverishment that they struggle to participate in their social spaces. So they're a really hard group to access. So it's really helpful to see what kinds of pathways we might find to reaching people who are most in need of stronger healthcare and social supports. I am happy to move on to Jessica Wong's question. Thank you for this very important discussion. I am in my early stages of my career and I would like to start engaging with community. So what are some tips and strategies to build an advisory committee and partner? Do you have any practical strategies for how to dip your toe into this kind of research? Who wants to take a stab at this question? Tara next.
I feel bad I was going first, but
Great at going first.
racing. Sorry, let me backtrack. CanChild, McMaster University offers a Families in Research Engagement course. I think it's FREC. The organization is called CanChild, and they offer practical courses of how you engage families of children with disabilities or all abilities in research. So you might want to look at their resources, maybe participate in their course and find out how to build the Family Advisory Council or a community-based council. The other thing too is I would say in organizations, we talk about partnership, but if you're in your early stages of your career, you're going to start to network. So who can you connect with who may have the community that you're interested in, speak with them and share your ideas with them and hear about their work as well. That reciprocal knowledge mobilization work is a great way to not start fresh and just don't think, I'm going to start a committee on my own, but look to advisory groups, to organizations that provide services and or programs within your local community or in a broader area to say, here's who does this well, here's their top priority, how do I fit in, and ask the question, how might I become involved in this work? Dilshad and Francis, do you have something to add to that as well?
Adding on to that is, was that Jessica Wong who asked that question, right? Is that Jessica? Correct. So Jessica, and you mentioned that this is your early stages. So now in describing, and again, when I started this conversation, listening from a Black man wearing a blue shirt with a tie, 5'11", you recall my introduction earlier? who has also faced multiple challenges in even breaking some of the doors to get in. My word of advice is resist the temptation to be perfect. Do not let perfection be the evil of the good. By that, what I mean is there is lots of organizations. Look at even the way we are here. This is a typical example of maybe one would say triple helix model, where you see a community health center, a center of specialization like Holland View and Grandview, but you are also seeing an institution like a university. There is lots that you are learning just by being here or by watching what's happening here, in which, those relationships, if you think, why academia, what's happening with community health center, what's happening with centers of subacute, which you are hearing here. These are opportunities for networks where you show up in these spaces and even ask a question, send an email to pose what you are trying to get to. Believe me, I see people paying for consultations to do this work. Here's the good news. It's very free and very easy to do through just a phone call and an email. You don't have to pay an expensive consultant to come tell you, talk to Terran, talk to Francis. It is free. So here's the beauty of what you have in our communities. If you are local or if wherever you are, understand the environment that you are in and the scope of some of the partners that are in the space. Some of them are actually champions in creating spaces for community-based research, and also setting network groups that either are already supporting families or have done through maybe 4 or 5 different iterations for research that has yielded maybe some revenue funding that is making those organizations operate. It's happening today as we speak in most of the agencies. And also for us as a plug, as a CHC, did you know today you can walk to any CHC out of the 73 of them here in the province, and you can say, I want this service for my family or for my loved one, and help me put it together. And I have even friends and networks there that are there. Did you know that it is something that could be done without having to break the bank of that organization? And CHCs are allowed within their mandate to create and build brand new from the start to meet the needs of the communities as they ask. We don't have to go and pledge to the government and ask for permission. It can be done within the backyard of your community to create these services and programs.
I just want to echo Francis's recommendations of networking. Just pick up the phone.
Yep, that's really sound advice. I think a lot about how to not just, I've already started my own research, Jessica, but how to start something new, how to build a new project. It requires a lot of on the ground work to build your network. That might be all the questions we mean to take today, and we're closing in at 1:30. I wanted to take a moment to thank our speakers for participating in today's panel and really enriching our series once again. I'm constantly astounded by the work that and the caliber you all bring to this series. I'm going to, before everyone leaves, put the next event registration link in the chat. If you are interested in joining our final installment, you can find the link by registering here. Hopefully I will see you all next month. Round of applause for our speakers and all our accommodation supports. Thank you so much for being such a great audience. Take care, everybody. I'll stop recording.